Welcome to the Speaking of Women's Health CME podcast. I'm your host, back in the Sunflower House. I'm Dr. Holly Thacker. I'm the Executive Director of National Speaking of Women's Health, our nonprofit, which is dedicated to helping women be strong, be healthy, and be in charge. Today's CME podcast is sponsored by a grant by Astellas and Bayer in conjunction with Rush University, Plexus Communications, Advancing Health After Hysterectomy, and Speaking of Women's Health. And you can find out more information about this program and our CME and other upcoming podcasts by going on menopauselearning.com. And at the conclusion of this podcast, I'll urge you to go back on that website so you can claim your free CME. Joining us today on February 1st on this CME podcast is Dr. Mary Jane Minkin. And she was part of our esteemed faculty for several lectures, which we have on menopauselearning.com. And she participated and led the interactive discussion last night that we had on a town hall, which is also posted and available for CME. So Dr. Minkin is a clinical professor in the Department of Obstetrics, Gynecology, and Reproductive Sciences at Yale University School of Medicine. She's been in private practice in New Haven, Connecticut for several decades. Dr. Minkin is board certified in OBGYN, and she also practices at the Yale New Haven Hospital. She earned her medical degree from Yale Medical School and her undergraduate degree from Brown University. And she did her internship and residency at Yale New Haven Hospital. She's a real Yaley, isn't she? The former in internal medicine and the latter in OBGYN. So she is quite well educated, as you can see. She's a fellow of the American College of OBGYN, and she's also a North American Menopause Certified Menopause Practitioner since 2002. Dr. Minkin has been director of the Sexuality, Intimacy, and Menopause Clinic in the Division of Gynecologic Oncology in the Similo Cancer Center at Yale New Haven since 2008. She's also been the director of the Yale OBGYN Society since its inception in 2006. So as you can see, she's quite the leader in women's health education inside and outside the medical community. And she's a lead author and co-author of numerous articles in the peer-reviewed medical journal, and she's written 7 books. Wow. Thank you for joining us in the Sunflower House, Dr. Minkin. Our topic today for this podcast is how do we anticipate integrating neurokinin inhibitors as well as holistic care into current midlife menopausal practice. So I want to turn it over to you, Dr. Minkin. Tell us a little bit more about yourself and also how people may be able to reach you, any social media or any links that you think our audience should know about.
Well, first of all, Dr. Thacker, thank you so much for the very kind introduction. I just could summarize what you said. I'm old and I've been doing this for a long time. It's fun. It's fun. And I love to take care of patients, and I love to teach my patients about what's going on with them. And I love to teach my students, my residents, medical students, fellows, whatever, about how they can further take care of their patients better. So, and that's part of the reason I'm very excited about the advent of neurokinin receptor antagonists on the scene, because I think this is really going to enhance our care of our patients. And one of the things you did mention that although I like taking care of teenagers too. I mean, it's not just menopausal ladies, but in taking care of menopausal women, which is really a great thing that we both enjoy doing very, very much, that I have sort of a special place in my heart for women who are cancer survivors.
Yes.
And this is a special group that really people hadn't paid attention to for a long time, maybe because cancer killed a lot of people, and now we're keeping people alive a lot longer, and they're surviving and they're doing great. I mean, they're cured. And these women have a whole lot of life ahead of them. And unfortunately, issues related to menopause and sexuality intimacy were really not dealt with very well for a number of years. And we've seen over the last 15 years, particularly, I would say, the growth of programs like ours, our sexuality, intimacy, and menopause program for cancer survivors, at Yale. And that, I really would like to let my cancer survivors lead totally normal lives and, go through menopause in an uneventful manner. And, both you and I, have been taking care of these ladies for a while. Me longer than you, of course. You're a youngster.
Not much, much.
Yes. But anyway, we both are very, very fond of using estrogen to take care of menopausal symptomatology, but there are sometimes women who cannot take estrogen. And we see these women day in and day out, and we feel really bad for these women who are suffering for vasomotor symptoms, which can be extremely hard for these women. And there are also people who just don't want to take estrogen for one reason or another, or women who can't take estrogen because of non-cancer issues, certain cardiac issues or other issues that would preclude them using estrogen. So that we really need to have an alternative. And both you and I have dealt with these issues for years about what options do we have for our patients. And there are some herbal remedies that do give folks some help, and there's no question about that. But as far as medications to help them, there really have been a significant limitation on what we can offer our patients. I mean, we all have used SSRIs, which are, of course, except for one product being used off-label for the vasomotor symptoms. And unfortunately, SSRIs and SNRIs have significant side effects themselves, which may not be great for our patients. A lot of our patients, for example, who are dealing with changes in libido, well, I don't really want to necessarily give them an SSRI and make their libido go away. That's not a really nice thing to do. We've used gabapentin for years, but some people get pretty tired and pretty bloated on it. Those are options that we have. We may give them oxybutynin. That's another possibility, and give them dry mouth and constipation. So basically, pretty much everything that we try to, or we can give them clonidine and let them pass out. So unfortunately, I used to be an internist when I was a little kid. So anyway, but I think about the side effects of all the medications we use, and that's why I was really excited and actually it was at NAMS, the first talk I heard on neurokinin B receptor antagonists was really at NAMS, that I was like, wow, these drugs sound pretty darn good to me. And the thing, as our studies have emerged on neurokinin receptor antagonists, we've seen that the side effects are pretty minimal and the medications are pretty effective. And the things that I really like about the neurokinin receptor antagonists is the fact that we can use these drugs in women who can't take estrogens. And to me, in looking at the literature that's out there and talking to people who've been doing the studies, that these medications take effect fairly quickly, which is important because women are looking for help and they don't want to say, well, I'll wait 3 months till this kicks in. No, I mean, we see results within two weeks sometimes in the neurokinin receptor antagonists. The other thing is we see very few side effects. And the other thing we see is that, again, very good effectiveness, very few side effects, taking place quickly. And these, to me, are winners. And again, we have not seen issues like depression of libido. We don't see this. So there are a lot of really good things qualities of these medications that I'm excited about, and I'm really eager to start using with my patients.
How do you think you're going to conceptually compare menopausal hormone therapy versus using a candy neuron inhibitor like Phaso, which we're hoping is going to, I spoke with Dr. Santoro, a research investigator, earlier today, and she's anticipating and hoping the FDA will approve a 45 milligram daily dose of Phaso.
And I'm certainly hoping that that's happening too. I mean, Danette has been working on this for a long time, and I am really very excited by thinking we're going to have this very soon. I mean, I must confess I've been telling my patients about this for about the last 3 to 4 years, and they're like, okay, when am I getting it? And I'm like, not yet, but it's coming close. So where's it going to fit in? Well, the key thing is this is a medication that, again, as we talked about, works quickly, seems to have few side effects, is really good, and it's really good on vasomotor symptoms. However, this is not going to be a drug that's going to supplant estrogen. And I think that we need to have estrogen in our armamentarium. And let's put it this way, as we talked about last night on our latest town hall for our learners about this, that there are certain things that these drugs will not do for patients. Okay, this is not going to be a drug for somebody who's got vaginal dryness. Somebody's got VVA or GSM to be the correct term these days, and she's suffering from that as well as hot flashes, and she can take estrogen. Well, I'm certainly going to encourage her to think about estrogen because otherwise I'm not taking care of her vaginal symptomatology. And a lot of other things that we know that estrogen can do. We know that estrogen certainly seems to help, although this is not an official indication, folks, for people listening for CME. I am not telling you to use it for this reason. However, we do know that a lot of women get achiness, that musculoskeletal discomforts. And Fezo is going to be a lovely drug, but I don't think it's going to help those particularly. That's not been what we've seen in studies. There are women who, again, have not official indications, but women who have not only a vaginal dryness but dry skin. Okay, that this is not going to be a drug that's going to, that Fezo's not going to make their skin moisture. So there are a lot of other things that our patients, even though they're not official indications, get out of estrogen therapy. They're not going to get it.
What do you think about the brain fog? Because that's a common symptom.
That's a good question. Do I think brain fog is going to be helped? I do think it's going to be helped. I think the Candy neurons have something to do with that as well. But I think, and again, part of the issue with brain fog that I've always been convinced about is that these women are going to get better sleep. And we do have some data on Fezo and sleep, that it's going to improve sleep for these women. They're not going to get up all the night flashing and things like that. And I do think a good part of brain fog is just these women are exhausted. And as I tell my residents that, we have the, residency review committees and stuff like that have legislated that residents can't be up night after night. We make sure they get a night's sleep. After they're up one night, they get a night's sleep. And I try to explain to my residents who are young that they just can't understand what a menopausal woman is going through who's up night after night after night with hot flashes. I tell them there's no residency committee that's going to mandate that my patients get sleep at night. Well, I think this drug is going to help them get sleep, and I think their brains are going to work a lot better when they get some sleep. So I am hopeful we're going to see brain fog lifted. Is it going to be the total answer? Probably not, but I think it's going to help.
Excellent. Is there any special evaluation that you do of women who are of the typical age of menopause who come in complaining of vasomotor symptoms? Are there other medical conditions you want to think about or rule out or make sure you're not missing before you just ascribe it to menopause, whether you're going to use hormone therapy or Fezo or any other alternative?
We'll be back after a quick break.
Hey, quick question for you. Are you someone who wants to be fit, healthy, and happy? And what if I told you could get your dream body by simply just listening to a podcast? I'm Josh.
And I'm KG, and we're the hosts of the Fit, Healthy, and Happy podcast.
Listen, we get it. Fitness isn't easy. Carbs, no carbs.
Just stop, okay? It doesn't have to be that complicated. And that's why we made this podcast. We get straight to the facts so you can become your best you.
So the way to check us out is click the link in the show notes or search Fit, Healthy, and Happy podcast on any of the major podcast platforms. We'll see you soon.
I must confess, I don't go looking for esoteric things in general. I must confess I don't. For somebody who comes in the normal age range and stuff like that. If I have a lady who's coming in who's 49 years old and she's been up at night and she's sweating and she gets up at 1 o'clock in the morning after passing out at 10 o'clock at night because she was so exhausted, and then she's up at 3 o'clock flashing and feeling miserable and finally gets to sleep, and she's experiencing vaginal dryness beginning, and she's having other menopausal symptomatology. In general, I'm not going to work her up for anything that's outside of menopause. I'm going to assume that's what I'm dealing with. Whether that's the appropriate thing or not, I don't know, but that's what I've been doing for years. However, there are people who I will work up. So, for example, and you've seen these people, Dr. Thacker, I know very regularly as an internal medicine person, that you have somebody who comes in who's 63 years old, okay, and she went through menopause. She'll say, this is the same at 49, for example. She went through menopause at 49, and her hot flashes have been really minuscule for the last 5 or 6 years. She really hasn't had any, and she comes in and she says, I'm really experiencing a lot of hot flashes right now, and I'm sweating at night and stuff like that. Do you think I need estrogen? And I'll say, no, I don't think you do. Or do I need vaso as a new option? Well, that's a person if her vasomotor symptoms have totally cleared for years, and she's got something else. I'm concerned about something else, and I don't know. Again, I'm not an internal medicine doctor practicing these days, but my first and simple test that I get on these people is I'll get a sed rate or a CRP, something like that, because I will look for some other inflammatory condition or a tumor or an infection, and I'll do a CBC with it for good luck too, just to get some initial things. And I might throw a set of thyroids in there, but I'll start doing some quickie sort of internal medicine evaluation to say what else is possibly going on here, because I'm not so sure this is most likely a menopausal symptomatology. I don't know. Is that what you do also, Holly? Is that something that how you approach these
it's
folks?
very interesting. I mean, I think it's not cost effective to waste money doing a lot of excessive testing. I know I see some residents wanting to work up pheochromocytoma and serotonin carcinoid syndrome, etc. I mean, it's nice to think about those things, I suppose, in a differential. I mean, I have a low index of suspicion when people complain of brain fog, of wondering, are they having a sleep disorder, sleep apnea? Are they depressed? Could they be hypothyroid, since 1 in 8 women have hypothyroidism? Did they start a new medication? That could happen, to make things worse. So those are just some of the kind of cursory things I think of. Sometimes when I see women who don't have hot flashes, or they have them but they're kind of over them, and then it's several years later that they seem to get worse, sometimes I wonder if their adrenal reserve and their ovarian stroma has kind of receded. So I don't rule out menopausal hormone therapy for those people, but I do think there's a subset of older women who just have thermoregulatory disorders that don't respond to estrogen necessarily. And then there's that group of women that are just hot all the time and sweating. And many of those women are very much overweight, and it's just like they're wearing a thick coat all the time. And those people, I find it hard to help with estrogen or with other agents, short of weight loss. And for those people, I worry about autonomic nervous system instability, and I check usually more intensely for diabetes. I might do a glucose tolerance test in those patients. My approach when I'm teaching residents and our specialized women's health fellows is, and I think anyone who's trained in the last, post WHI, who've kind of been anti-hormone, most of my trainees come in looking for reasons not to prescribe hormones. And so I like to flip it the other way. Like when you look at someone who stopped their menstrual periods, or, is of the age, maybe they had a hysterectomy or an ablation, or they have a Mirena in, are you menopausal, yes or no? Just because they're not complaining, or just because they say they're in menopause, of course, doesn't mean they are. And I don't think there's enough attention on actually how you diagnose perimenopause and menopause. And certainly we know that perimenopause can actually be worse for vasomotor symptoms. And I had asked Dr. Santoro if she thinks that there's a role for the neurokinin inhibitors in perimenopause, and she thought less so, because the hormones are fluctuating so much. And I wondered what you thought.
Well, I must confess I share some similar thoughts, as far as, again, maybe I shouldn't admit this in public here, but I am a great believer if something is pretty safe to use. I'm a great believer in some empirical therapy and say, let's see if it works. So I must confess I may be doing this off-label, but I have a feeling I'm going to be using Fezo and some of my perimenopausal ladies and see what it does for them, because I think that some of these people will benefit by it. And again, as you point out, quite appropriately, that the hot flashes, the vasomotor symptoms can be actually far worse in the perimenopause than they can once the patient gets to be fully menopausal. So these women can be pretty miserable. So I think that, and to be honest, if somebody is a candidate for estrogen. I must confess I will very often empirically slap a patch on because I think that the side effects, potential side effects from a patch are pretty darn small in somebody. And I also must confess if I have somebody in perimenopause, I will not put them on any progestin or progesterone right away. I'll just empirically give them a couple of months of estrogen and see how they do. And I often will use a patch and say, let's see what happens over the next couple of months. And I explain to them, there are going to be days they're going to be mad at me because their breasts are going to kill them because I'm giving them some estrogen on top of some own endogenous estrogen production. But again, this is a shared decision making. I mean, this is not me making a decision, but I throw this out as a possibility that we can think about doing. And I will do that periodically and say, let's see if we make you feel better. So these are things that, and I do see a role for Fezo at some point in the future. Again, totally off label because it's officially not indicated for perimenopausal stuff. But I anticipate that I think not only, I will not be the only person using it for that indication as well.
Yeah, I think we'll probably want to use it in a lot of these tough patients we see. I did ask her if there was any data, animal data, in pregnancy, because obviously in perimenopause you could ovulate. So I'm not concerned about giving estradiol or progesterone in a perimenopausal woman who could potentially ovulate and get pregnant, just like I'm not concerned about giving a birth control pill where someone might, become pregnant as well. But other agents I'm a little bit more hesitant to. But getting back to that, getting first the diagnosis, are you in menopause, yes or no? It's not always that obvious. My next question is, do you have symptoms, yes or no? And I think symptoms are a lot broader than what we always classically teach in terms of hot flashes, night sweats, sleep disturbance, potentially brain fog. I mean, I think some of these other somatic symptoms, joint pain, just not feeling like the same person. My next decision tree is, do you have a uterus / endometrium or not? And again, that seems pretty easy, but if you don't get those op reports and look, there's plenty of women who say they've had a hysterectomy and they just had a myomectomy. I've given unopposed estrogen and examined a woman, saw an atrophic vagina. I didn't see a cervix, and then you give estrogen, and then all of a sudden there it is, and they're bleeding. So I really do think it's very important, and it shocks me that patients, and it includes physicians and nurses as patients, they don't have copies of their surgical reports or their pathology reports, and they think everything's, quote, on the computer. Mm-hmm. Well, not everything is, and not everything connects. So I think that's an important distinction, and we do see a lot of severe endometriosis, and even if the uterus isn't there, you still wonder if you need to worry about the endometrium. My next decision point is, what's your bone status? And we have no indication that Fezo is going to help the bone, whereas we have lots of evidence that estrogen's excellent in protecting bone health, reducing fractures, even in women who don't even have osteoporosis. And then finally, my last decision tree is, what's the genitourinary status? Because 80% of women eventually are going to have some changes in the GU tract. And so I see Fezo as being excellent for just affecting the vasomotor symptoms without stimulating the breast or uterus being an issue in people necessarily, even though it hasn't been specifically studied in breast cancer patients, blood clot patients. Obviously, those are the most urgent cases. We're going to want to avoid estrogen and have this as an option. Although, and we do have on menopauselearning.com that excellent discussion between Dr. Heather Hirsch and Dr. Avram Blooming on using hormones in breast cancer patients. It's certainly not standard, but I mean, certainly I end up needing to do it some of the time, and I'm sure you do, anyone who has a referral practice, but it's certainly not routine, that's for sure. So I would just make the plea that, when this gets on the market, I think that there's going to be a definite need for a niche. I would just say, I don't think we need to forget the bone and forget the GU tract, because I see that in women who are on Neurontin, or they're on NSRIs, or they're on other agents, or their brain just isn't wired to flash. And then nobody else thinks about anything else related to estrogen deficiency. And I think that's just such a shame. It's such a critical lost opportunity for prevention. Do you have any thoughts as to why some women just are not wired to flash and others do their whole life?
Well, that's another excellent question. And this is actually my way of trying to trick medical students to think about OBGYN as a career, particularly menopausal medicine, because the way we started out when we talk about it, about of 100% of women, 20% are going to get severe hot flashes. Another 60% are going to be middle. They'll get some hot flashes, but they won't be horrible. And then 20% of women basically get no hot flashes to speak of. And why don't these women get hot flashes? But there are a lot of them out there, and we don't know. And I don't know why. And I think learning more about the brain and learning more about the hypothalamic and the KND receptors, I think, is going to teach us a lot. And I think this is a burgeoning area. And as I tell my medical students, I don't care if you don't want to get a Nobel Prize, but your mother wants you to get one. And I said, if your mother wants you to get a Nobel Prize, this is a great area for research because this area is just opening up. And there's going to be, I think we're going to accrue a lot of information over the next few years about what's going on with KND receptors, what's going on in the hypothalamus. One of the other things that I'm interested in is, we know that certain herbal products do have some properties against hot flashes. Well, are they acting in a sense like neurokinin receptor antagonists? Is that possible? I don't know. But I think there's going to be a lot of work that's going to be done along those lines. And I think that's exciting. I think it's
When
fabulous.
I was interviewing Dr. Khan, who gave the lecture in our series, since she's certified in both menopause but also functional medicine. So she sees a lot of women who don't want any prescriptions. They only want supplements or a functional medicine type approach. She said that a lot of infusions of peptides are being used. I mean, I'm always concerned about the level of evidence, not that randomized controlled trials are the end all be all for all questions. And we certainly have to look at all lines of evidence and use our clinical judgment and not deny people the option, for treatment simply because we don't have the highest level of evidence that we all would like. And we all know that, of course, there's a huge placebo response in almost all trials, especially hot flash trials. So there's that. Are there any potential herbal products or supplements that you use in your practice, especially with respect to the breast cancer survivors, the sexual dysfunction patients you see?
Yeah, there are a couple that I use pretty often, and I have to make a disclaimer here. I do consult for some of these folks, and the reason I consult for them is I use the products, and I think they work. Probably the best example I think that we have, and we do have a fair amount of literature, even though, I have to come out as a active NAMS member. NAMS does not basically believe in any herbal supplements.
Yeah,
I
know.
can
They
tell
are
you
pretty.
right off the top. And so I have to say I love my NAMS friends. I love it all. But I do believe there are certain supplements that do work. And there is a fair amount of data on black cohosh. The problem is with the United States that our herbal products are so poorly supervised that you really can't do much studying in the United States with any of the herbal products. If you get some of the folks from Europe, particularly the Germans, the Swedes, things like that the Germans basically have a PDR for herbal products, and you can't get things approved unless you go through their PDR type process, which is pretty good. So you're going to get a pure product. And so then German breast cancer centers, the number one product that they use over there is German black cohosh, which is remifemin. And there's a lot of literature on it. And one of my I am really curious to see, maybe somebody will find out that that's the path that it works by, that maybe there's some, KND receptor activity that's going on with the remifemin. But because they use it regularly in German breast cancer centers, and they actually, but the interesting thing is it may not just be totally KND receptors, because they actually have shown some hormonal type activity in a sense, because they show some apoptosis, for example, increase in people who are using remifemin. And I don't know if I can say that Fezo or something like that would do that. I don't know. Maybe it can. But I think there's a lot of area that we may see some stuff coming on along those lines, looking at products like, remifemin.
And in Germany, that's actually a prescription herb, and it's just only to be used for 6 months. Is that right? And is there some concerns about liver function?
No, there actually isn't. And I actually did a paper on this.
Where was that published? Yeah.
It was published, I can't remember, I think it was in Menopause, a number of years back. Basically, we looked at all the trials that have used remifemin as opposed to the ones that have used generic black cohosh. And there are LFTs as part of all the studies that have used the name brand of Remi, have LFT data. And there is no increase in abnormal LFTs. on the, and I think there were well over 1,000 patients in the studies, the name brand studies. So there does not seem to be. The major issue with the 6 months actually is that the question is, do you need to take it for more than 6 months? In other words, are you getting better on your own? And so they recommend checking every 6 months or so to see, do you need it anymore? Are your hot flashes better? Because we do know over the course of time, hot flashes will get better. So that's the reason they have these 6-month statement on there, is just to go off to see whether you really need to be on it anymore, or are you better enough.
And in your practice, what
That's
have you
the goal.
found? Do people usually go off in 6 months or a year, or do some people use it longer, just like any other substance?
We'll be back after a quick break.
Have you ever experienced fitness failure? You set a goal to exercise, you're all excited, and then you're not. Hi, I'm Dave. I host the daily 10-minute podcast, Walking is Fitness. Instead of an exercise goal, I talk about making a fitness promise. And every day you keep that promise, you add another link to a growing fitness chain. This is a podcast of action. You'll create a fitness habit, which eventually becomes fitness momentum, and then onto all kinds of good stuff. Check it out. Walking is Fitness, and let's take a daily 10-minute walk together.
Like any other substance, pretty much is the way my folks treat it. And again, it's among our breast cancer patients, particularly, that has been, in general, one of our first go-tos for them. Mimicking the German folks is what they use in their breast
And then if that
cancer
doesn't
centers.
work in your breast cancer patients, what's your next line?
My next
Yes.
herbal? My next herbal that I use is, I do think Relazin works pretty well for a lot of people, which is a Swedish pollen extract. I've had pretty good luck with that. And again, there is data. Steve Goldstein's done a couple of papers on that, actually, and showing that it probably acts more like an SSRI. So it probably has SSRI type activity.
Is that over the counter?
Yep, it's over the counter. It's available online, but it's over the counter. And probably, again, SSRI type activity. Reasonable drug. The problem with that is it takes a little bit longer to kick in. As far as effectiveness, it may take a couple of months to really show activity. The black cohosh, the Remy's, tends to start a little bit more quickly than that. So those are two that we've had pretty good luck with and we use fairly regularly.
And is there any dosage adjustment with or without food? Patients who are already on SSRIs or NSRIs, is there any issue?
No, there doesn't seem to be, and that's been looked at, no significant interaction with the SSRIs that they're on, so you can have somebody with SSRIs using it, it's okay. As far as titration, in general, no, it's with Remy, you can titrate it a bit. Relazin's pretty much a 2-tablet-a-day thing, and there's not a lot of titration. With Remifemin, you can use more. The standard dose is like 40 milligrams a day, but there are some studies showing some efficacy going up to as much as 120 milligrams a day.
And what other clinical caveats and tips do you have for physicians dealing with breast cancer or other cancer survivors whose hands are tied and aren't using hormone therapy?
Okay. Well, to date, since I haven't had Fezo to date, maybe talk to me next month at this point, maybe we'll be talking about it a little bit more, that I basically tried again, and we talked a little bit about this in our town hall, which I would encourage everybody to listen in on the website that I think that it's going to be up there very shortly. I think,
yes,
right,
menopauselearning.com.
Menopauselearning.com, that the town hall will be up there. That one thing that Dr. Iyer and Dr. Pfiffick and I were discussing last night is that we all like to get sort of, I hate to say it like this, as much bang for the buck as you can. So if some of these medications that we're using are really they're off-label, what we're using for is hot flashes, they have another purpose in life. I try to get a twofer. If I can get, for example, if I have somebody who, and the example I used last night, if I have somebody who's having significant somatic pain, and again, my standard example is our patients who are on the aromatase inhibitors. A lot of people on aromatase inhibitors have achiness. And so if somebody is having hot flashes and achiness, there isn't a lot of data on duloxetine, trade name is Cymbalta, as far as is that specifically good for hot flashes, but it's a pretty good SNRI, and it does work for hot flashes. I will suggest maybe we should try duloxetine because, well, we're going to help with your hot flashes probably, and we're also probably going to help with your somatic pain because it as an official indication for somatic pain. So I think that that's a good combination. Or, for example, another example, we know that oxybutynin does, again, this is all totally off-label, it seems to help with hot flashes. Well, if I have somebody that's got urge incontinence, and we know a lot of our patients have urge incontinence, and I'm thinking about a drug for that, well, if I can give her oxybutynin, then I can help with her hot flashes and her urge incontinence. So that's a good thing. If somebody's having sleep problems, particularly, well, gabapentin tends to make people sleepy. So if she's getting hot flashes and her sleep is particularly bad, I might say, well, why don't we try some gabapentin so I can help your sleep too. So there are certain, other effects of what these drugs really do to say maybe I can get two activities out of the drug as opposed to, just one
Now,
activity.
in the breast cancer patients on Cymbalta and NSRI, if they're on tamoxifen, obviously we don't like to use an SSRI like Paxil because that affects the metabolism to endo-tamoxifen, maybe reducing the effectiveness of the drug. What do you think about with Cymbalta, Effexor, Pristiq, or venlafaxine to use the generic names?
Yeah, they're not a problem with the CYP2D6s in general, so I think it's quite a reasonable option for these people. So the major reason I had it in an AI person is the tamoxifen ladies sometimes get a little achy, but the AI ladies get really
they sure
achy
do.
in
Do you
general,
find
so.
if they switch, because there's like these three major AIs, that some tolerate one aromatase inhibitor much better than another?
The answer is better. I don't know that I would say much better, to be honest, but I would say better. So I think it is worth. I mean, the one I think my oncology buddies seem to go to, I think, is exemestane. They tend to switch over to. They seem to think a lot of people have less achiness on it.
I think that one's more
I mean,
expensive, but
certainly.
I do see them switching to that. I tend to try to keep all my 25 hydroxy vitamin D levels over 50. I think that helps some of these people. And if they don't have shellfish allergies, I push glucosamine, chondroitin, and sulfate.
You and me both, and that I should have mentioned. Yes, I am a big glucosamine pusher,
Yeah.
so I have them.
I know.
have
I
'em on
started it
glucosamine,
years ago, and patients would look at me and they're like, my dog takes that. Oh, my goodness. But,
Well, can I make a
yes,
confession
go
here?
ahead,
I don't know if
please.
it's appropriate. Well, I myself am a glucosamine user because of my knees, which started misbehaving about 14, 15 years ago, and I'm still on it. And one of the major reasons I decided to put myself on it, I said, hey, the vets use it for dogs and horses. I'm as good as a dog or a
That's
horse.
right.
Let's try.
Well, actually, in women, there is pretty good data for knee OA. Like I see women who have hand OA, and I tell them the data's not as good for that, but for knee OA for sure. And that's one benefit, of course, with hormone therapy. We know if women need more knee replacements and hip replacements compared to men, and women who undergo a major joint replacement, if they're on menopausal hormone therapy, they tend to have better longevity with their joints. And so I think there's a lot of subtle benefits in that regard with hormone therapy that we're not going to see with the non-hormonal alternatives. On the other hand, obviously women on hormone therapy, increased risk of gallbladder disease, breast stimulation, potentially more false positive mammograms, bleeding. It's very hard to keep a woman in my practice over 60 or 65 on hormones if they have a uterus. Not always, but I mean, I have people in their 90s still on hormones who have a uterus, but I can count those women on one hand. So, and we can't just go around having everybody get hysterectomies, even though it makes our life easier.
It does make our lives easier, but no. And one of the concerns I do have, all kidding around aside, is I am concerned about people thinking about Fezo, which is an excellent drug, just saying, well, they got hot flashes. I don't want to handle bleeding. I'm just going to put them on Fezo because they're not going to bleed. And I think that to deprive somebody of estrogen just because she's got a uterus and you're concerned about the risk of bleeding, and the other thing, maybe I shouldn't say this, but that never stops me from saying anything. Your fellows that you've trained, are internal medicine folks, but they're totally comfortable in handling vaginal bleeding, and they know how to do an endometrial biopsy. And there are, unfortunately, many primary care folks who are really anxious about vaginal bleeding, and they get nervous when the patient starts bleeding, and they just say, okay, now you're off of the estrogen, and we're going to switch you. And they may say Fezo, which again is a lovely drug, but they won't be getting the benefits of estrogen therapy.
I see the same thing with OBGYNs who clearly should be happy to deal with bleeding or gynecologic problems. Sure. And I still see them go first line for an SSRI. And we only have one SSRI that's labeled as such, Brisdel, 7.5 milligrams of paroxetine. So I think that's a pervasive problem to just think of menopause as hot flashes in isolation. On the flip side, hot flashes can really be very detrimental and disturbing and affect people's life, their work productivity, their relationships. And so it needs to be treated and not just minimized. Well, this has just been an excellent discussion. Thank you so much, Dr. Minkin, for your time, for your insights. We're going to have you back in the Sunflower House on a Speaking of Women's Health podcast. And I understand for more information about you and your practice, is it true that our listeners can visit madameovary.com?
Yes, madameovary.com. That's, or as I introduce the topic to people, I say, as Miss Piggy would say, Madame Ovary, c'est moi.
You have a little French in there, I see.
So, Madame Ovary, that's me, madameovary.com. And please visit, because I've got some fun, it's aimed towards intelligent patients and young practitioners, because the other thing we haven't touched on, which we can maybe touch on in a subsequent chat, is the fact that menopause education went by in the year 2002. And unfortunately, some of our younger practitioners really weren't trained in menopause management. So I hope that some younger practitioners may want to come to madameovary.com and see some of the stuff on there, because it's aimed towards young practitioners.
Oh, that's great to have this as a resource. And you mentioned NAMS, menopause.org, which is a great organization, and I've been part of from the very beginning, actually. But as any kind of consensus-driven, more conservative type organization, I think sometimes they're a little bit too circumspect. Like, that's the organization that lists lubricants as first-line treatment for atrophy, which I really have a problem with, because when the tissue integrity is not healthy, simply slapping on a moisturizer, it's going in with a skin disease and the dermatologist saying, just put a little, moisturizer on it. I just don't think that that's the best way to go, but that's my practice, and my personal approach is offering a lot more, and sometimes that's too much. Some people want a lot less. That's why I think it's good to have alternative approaches and holistic and functional medicine, which we've tried to incorporate with this grant. And so I would encourage all of our listeners to go to menopauselearning.com, claim your free CME. There's lots of great lectures that are up there, and Dr. Minkin just had several more recently posted. So we thank you for tuning in to the Speaking of Women's Health podcast, and we hope that you'll join us again for our next learning episode. I'll be interviewing Dr. Camille Moreno, one of my graduates, and she runs the midlife program in Utah. So thanks so much for joining us in the Sunflower House.